and the darkness swallows me whole. I speak pain, breathe pain, bleed pain. Every pulse aches pain. It is everywhere around me. It's everything I see. And then my soul is lifted from this mire, from this pit. Elated high, my spirit sings, my spirit dances. I am invincible, everything is possible, dreams are mine. I soar, I sing, I fly, everything is tinged with glorious beauty. I am racing, a downward spiral towards the darkness where it waits to swallow me. Can't calm the thoughts that threaten me, attack me. Terror speeds me, I can't stop this downward fall. The tears aren't flowing yet, but they will come.
Bipolar disorder, otherwise known as manic depressive illness, is a relatively common but serious psychological disorder that is characterized by intense, severe fluctuations in mood. It is important to understand, though, that these oscillations in mood aren't your everyday experiences of ups and downs, but rather overwhelming emotional changes that can lead to damaged relationships, poor performance in school or work, and even suicide. Affecting about 1% of the general population in a lifetime, bipolar disorder often involves unusual shifts in energy and loss of ability to reason and function normally. Symptoms and severity may vary from one individual to another, but in order to be diagnosed with bipolar disorder, individuals must have experienced some sort of alteration between the two mood episodes, known as manic and depressive. The periods of extreme highs in which a patient experiences intense excitement, irritability, euphoria, agitation, and/or energy is called the manic episode. DSM-5 requires a duration of only 1 week. In this phase, a bipolar person will display several or all of the following behavioral changes. They might talk loudly, rapidly, and continuously without stopping, or be easily distracted by little things, not feel the need to sleep or rest, deny that something is wrong with them, take on multiple new projects at once and develop grandiose plans, be overly confident, enthusiastic, or optimistic, and engage in impulsive, pleasurable, and risk-taking behaviors such as drinking excessive amounts of alcohol, abusing drugs, or engaging in promiscuous sexual activity. Hypomanic episodes are, put simply, less severe versions of manic episodes. They typically do not cause marked impairment in social or occupational functioning and only last about 4 days, rather than 7. During depressive episodes, a person defined by feelings of hopelessness, sadness, lack of energy, and decreased motivation, a bipolar person might have problems concentrating, remembering, and making decisions, experience weight loss or gain due to a change in eating habits, lose interest in previously enjoyable activities, such as spending time with others, exercising, or sex, feel overly tired or slow, have problems related to sleep, think about ending his or her life, and/or attempt suicide. Psychological evaluations such as SCID, Structured Clinical Interview for DSM-5, or SADS, Schedule for Affective Disorders and Schizophrenia, are the most commonly used methods of assessment for bipolar disorder. Information from self-report surveys and questionnaires, as well as reports from family members, friends, and colleagues are also used to make a diagnosis. According to a summary of various articles written by K. Ranga-Krishnan, the majority of patients with bipolar disorder have at least one comorbid psychological problem, such as anxiety disorder or substance abuse disorder. Therefore, diagnosis of bipolar disorder often does not occur for a while after an individual begins experiencing the symptoms. Bipolar disorder can be divided into several subtypes, and each carries a different pattern of symptoms. According to the DSM-5, diagnosis is based on the following criteria. In bipolar I disorder, an individual alternates between major depressive and manic episodes. A person may only have had one episode of mania as opposed to several instances in order to be diagnosed with bipolar I. Bipolar II is similar to bipolar I, but can be seen as less severe. Instead of switching back and forth from major depressive and manic episodes, an individual experiences symptoms of major depression and hypomania, a less severe mood state. Psychothymic disorder is a chronic but milder form of bipolar disorder characterized by alterations between mild depressive and hypomanic periods over the span of 2 or more years. People with psychothymic disorder rarely experience periods of neutral or euthymic mood, and their depressive and elevated mood states don't require immediate course of action, such as hospitalization. These individuals are often described as moody, but their affective states do interfere with everyday life. Rapid cycling bipolar disorder is thought of as the most severe form of the disorder. Patients undergo rapid cycling only if they have had 4 or more manic, hypomanic, and depressive episodes within a year. Studies have shown that women and people who develop bipolar disorder at younger ages tend to display such patterns more than other bipolar patients. Like many other psychiatric disorders, scientists generally agree that there is not a single cause for bipolar disorder. In fact, an interplay of a variety of factors, including biological, psychological, and environmental, contribute to its etiology. Several biological factors associated with bipolar disorder, including genetics and familial history, abnormalities in brain structure, and irregular levels of serotonin, dopamine, and norepinephrine. One study published by Dr. R.M. Post and others, titled The Bipolar Maze, explored the potential genetic and familial influences on the onset of bipolar disorder at an early age. They found that patients whose parents who were both diagnosed with bipolar disorders, as opposed to those with one or no parents with a history of mood disorders, were more likely to develop bipolar disorder. While there were many twin family and adoption studies, such as the one done by the Institute of Psychiatry at King's College London in 2011, conducted to identify a specific epigenetic marker for bipolar disorder, success has been extremely limited. Still, to this date, scientists are working to figure out which specific genes or genomic regions cause individuals to be at risk for developing bipolar disorder. Some research also indicates that abnormalities in brain structure could be responsible for bipolar disorder. More specifically, based on images produced by MRIs during an experiment conducted by the Bipolar and Psychotic Disorders Research Program at the University of Cincinnati, an enlarged amygdala was observable in bipolar patients. An abnormally large amygdala, a crucial structure in the brain responsible for human emotion regulation and motivation, could explain why people with bipolar display irregular, unstable mood patterns. Decreased levels of serotonin are also commonly found in bipolar patients. Many medications used to treat bipolar disorder work by increasing levels of serotonin in the brain, as we will see later in the video. Dopamine is another neurotransmitter that plays a role in bipolar disorder. Researchers observed high levels of dopamine during manic stages and downregulation during depressive episodes. Thus, it is thought to be responsible for the cyclic mood shifts observable in bipolar patients. Overactivity of norepinephrine is also associated with mania, and deficiencies account for depressive moods. Although there are many biological factors contributing to the etiology of bipolar disorder, many external factors can trigger its onset as well. Being under constant stress, losing a loved one, or other traumatic life events such as losing a job or witnessing a violent crime can all cause a genetically predisposed person to begin showing symptoms of bipolar disorder. An individual's inability to normally regulate his or her emotions, thoughts, and behaviors in response to the environmental stressors like these might signify psychological risks for developing the disorder. It is crucial to understand that bipolar disorder is not caused by one specific factor, but rather is a result of a complex combination of biological, psychological, and environmental influences. The prognosis for bipolar disorder varies from one subtype to another, but with an accurate diagnosis and a commitment to a long-term treatment plan, its symptoms can be controlled. Typically, a patient with bipolar disorder will receive a combination of pharmaceutical and psychological treatment. The three most commonly used types of medication are mood stabilizers, atypical antipsychotics, and antidepressants. Mood stabilizers are the go-to drugs for treating bipolar disorder because they are designed to treat episodes of mania, hypomania, and depression that last several days or weeks at a time. Lithium, the oldest and most popular choice of medication, is especially effective in preventing manic episodes and is known to reduce the risk of suicide in bipolar patients. However, its dosage has to be carefully controlled because taking too little will produce no benefits, and taking too much can cause serious kidney and thyroid problems. Its mechanism of action remains relatively unclear as well. Anticonvulsant medication, originally developed to treat seizures, like valproate, carbazepine, and lamotrigine, are also used as mood stabilizers. There is now evidence, as reported in the Journal of Psychopharmacology, that some antipsychotics, like aripiprazole, haloperidol, and olanzapine, when taken with lithium or valproate, can prevent episodes of acute mania better than mood stabilizers alone. According to the same article, this class of drugs could also be useful in treating rapid cycling. Antidepressants are also prescribed, usually in addition to mood stabilizers, to treat bipolar depressive symptoms. Research indicates that when taken alone, antidepressants can trigger manic episodes or rapid cycling symptoms. Dr. Malcolm Peet, a research specialist, discovered that tricyclics, common antidepressants that block the absorption of serotonin and norepinephrine, were twice as likely to cause a manic episode in bipolar patients than SSRIs. Cognitive behavioral therapy is the most prevalent form of psychotherapy provided in conjunction with medications to help patients change negative thoughts and behaviors. During CBT sessions, patients are taught useful strategies to manage stress and cope with the symptoms of mania and depression. Other methods of psychological treatment involve family therapy, interpersonal and social rhythm therapy, and psychoeducation, all of which are designed to lead patients into recognizing the faulty, self-constructed nature of their thought patterns. Recently, researchers have started investigating the more unconventional methods of therapy, such as transcranial magnetic stimulation and electroconvulsive therapy. In particular, ECT, formerly known as shock therapy, has gained much attention from modern psychologists and is now being recognized as a perfectly safe and valid form of treatment. Audit findings by Dr. S. Mukherjee indicated that 80% of manic patients expressed noticeable clinical improvements from ECT. Assuming that more active research will be done on the benefits, mechanisms, and side effects of ECT, the future of ECT as a therapy for bipolar patients who are otherwise treatment-resistant seems rather promising.